Greetings and welcome, participants. I'm Dr. Leslie Lomo, an Associate Professor of Pathology, an Associate Surgical Pathologist, and Cytopathologist in the Department of Pathology at University of Utah here in Salt Lake City. I'm so excited to be a part of the continuation of the Africa Calls series under the mantle of the American Society for Clinical Pathology and working closely with Dr. Milner in this excellent educational effort. It's my great honor and pleasure to introduce Dr. Vicky Zhou as our guest speaker today. Dr. Zhou is an Associate Professor of Pathology at Harvard Medical School and an Associate Surgical Pathologist and Cytopathologist at Brigham and Women's Hospital in Boston, Massachusetts. Dr. Zhou completed her medical training and combined anatomic and clinical pathology residency training at the University of Virginia School of Medicine and Health Systems, followed by fellowships in surgical pathology and cytopathology at Brigham and Women's Hospital. Dr. Zhou has published, currently, in addition to her multiple clinical and teaching activities, Dr. Zhou is currently serving as the interim chief of their head and neck pathology service. Dr. Zhou has published numerous peer-reviewed articles and book chapters to date, establishing her expertise in the areas of both surgical pathology and cytopathology of head and neck and soft tissue tumors, including contributions to the latest editions of the WHO classification of soft tissue and bone tumors and CNS tumors, among others. Dr. Zhou has given multiple invited lectures throughout the US and internationally. In fact, long-standing participants of this Africa Calls series may recall she gave a presentation in 2016 on a practical approach to fine needle aspiration of soft tissue tumors. We are so thrilled to have her back with us again today to take us through the cytologic diagnostic approach specifically to pleomorphic soft tissue sarcomas. So with that, I'll turn it over to Dr. Zhou.
Well, thank you, Dr. Milner and Dr. Loma, for the invitation, and it's always a pleasure to participate in this outstanding series. Today, we'll talk about cytologic diagnostic approaches to pleomorphic soft tissue sarcomas. When we specifically are referring to pleomorphic soft tissue sarcomas, we are referring to aggressive malignancies that typically arise in adult patients. Pleomorphism specifically describes these tumor cells having significant variation in size and shape in tumor cells and in their nuclei. And these tumors, you can imagine, are often associated with high mitotic activity and necrosis. Notably, tumors in the differential diagnosis can be very difficult to distinguish from one another on morphologic grounds. However, it is important to subclassify these tumors because of varying metastatic potentials for each entity. This table shows the entities that we'll discuss today and shows their differing metastatic rates. You can see for dedifferentiated liposarcoma, these tumors show metastatic rates between 15 to 20%. In contrast, pleomorphic leiomyosarcoma and pleomorphic rhabdomyosarcoma show significantly higher metastatic rates of 70% and greater than 90% respectively. Tumors vary in metastatic rates between those two spectrums, include myxofibrosarcoma, pleomorphic liposarcoma, undifferentiated or unclassified pleomorphic sarcoma, and extraskeletal osteosarcoma. And today we'll review the salient cytopathologic features and relevant ancillary studies that can help you address this differential diagnosis. What are some helpful clinical correlations in the differential diagnosis that can help you from the start when you encounter one of these tumors on aspirate smear? Well, it's important to remember that in the extremities, myxofibrosarcoma is the most common sarcoma, particularly in elderly patients, followed by unclassified pleomorphic sarcoma. While it's important to recognize these other entities, pleomorphic liposarcoma, pleomorphic rhabdomyosarcoma, and extraskeletal osteosarcoma, it's also important to remember that these are actually very rare. In the retroperitoneum, any pleomorphic sarcoma that you encounter should have dedifferentiated liposarcoma as a chief diagnostic consideration, as this is by far and away the most common pleomorphic sarcoma that arises in this anatomic site. However, pleomorphic leiomyosarcoma and pleomorphic carcinomas should be considered if dedifferentiated liposarcoma is excluded. All other sarcoma types, including these other pleomorphic sarcomas, are exceptionally rare in this location. And one last thing to remember is that pleomorphic leiomyosarcoma may often be associated with a large vessel, although this may be appreciated only on imaging studies or on gross examination of a resection specimen. We're all aware that FNA and core biopsies of soft tissue tumors overall can be very challenging. I do encourage anyone who has the resources to consider triaging tissue for cell block preparations, as ancillary studies can be helpful in this differential diagnosis, or to avail yourself of any concurrent core biopsies and to coordinate the diagnostic efforts on both ends. However, while several tumor types have indistinct immunophenotypes and complex genetic profiles, there are other tumor types for which defining immunochemical genetic features can be detected on the cell block material. Unfortunately, in some scenarios, definitive diagnosis is only possible in resection specimens, and thus we are relegated to using descriptive FNA diagnoses, as some entities require thorough sampling to identify defining histologic features, and we'll discuss such examples throughout this talk. And so the ancillary studies I've referred to include immunohistochemistry, and we'll go over these examples, but briefly, 4 entities have immunohistochemical features that we can identify. So these include dedifferentiated liposarcoma with MDM2 and CDK4, pleomorphic leiomyosarcoma using myogenic and smooth muscle specific markers, smooth muscle actin, desmin, and caldesmon, pleomorphic rhabdomyosarcoma with desmin, myogenin, and MyoD1, which are skeletal muscle specific transcription factors, and SATB2 for extraskeletal osteosarcoma. It's important to also include in your panel of any pleomorphic malignancy, keratin to exclude a poorly differentiated or undifferentiated carcinoma, S100 or SOX10 to exclude melanoma if that's a consideration in your differential diagnosis, and of course, LCA to exclude anaplastic large cell lymphoma, which can be a mimicker in rare cases of a pleomorphic sarcoma. So let's start off discussing dedifferentiated liposarcoma. These tumors arise in adults and are notably rare in younger patients, specifically less than 40 years of age, and almost exceptionally rare in young pediatric patients. As I stated before, the retroperitoneum is the most common site. These may also arise in other deep-seated or visceral locations, including the abdominal cavity and mediastinum, and these are rare in somatic sites, such as specifically the limbs. However, when they do occur, they often occur in subfascial or deep-seated locations. These tumors suffer a very high local recurrence rate, and this can cause high rates of morbidity over the years for affected patients. But as stated before, amongst the pleomorphic sarcomas, these show the lowest metastatic rates of about 15 to 20%. And specifically, dedifferentiated liposarcoma represents transformation of a precursor atypical lipomatous tumor, orbital differentiated liposarcoma. Those tumors, ALT and WDLPS, are considered synonyms. So represent transformation of ALT or WDLPS to a non-lipogenic sarcoma. This dedifferentiation is time dependent, and so you can imagine these would most commonly occur in the retroperitoneum, where a precursor fatty tumor can grow undetected for some time. And you may have a history either by imaging or a prior biopsy of an associated longstanding fatty mass. The thing that's important to remember about dedifferentiated liposarcoma is that these show highly variable morphology and heterogeneity within a tumor, and thus dedifferentiated liposarcoma enters many pattern-based differential diagnoses. And so what I've shown here are not just the pleomorphic pattern, as you can see on the upper left, but other patterns that dedifferentiated liposarcoma can enter. So some tumors shown in the middle and on the right top can appear myxoid, in which they may even mimic myxofibrosarcoma. You can see on the bottom left panel that some examples show a more spindle cell component. And in some cases, such as shown in the middle, You can even have an epithelioid or round cell appearance to dedifferentiated liposarcoma. And while I mentioned that dedifferentiated liposarcoma often represents a non-lipogenic sarcoma, some tumors may actually show fatty differentiation as shown on the bottom right. So a typical smear of dedifferentiated liposarcoma admittedly looks not very different from other pleomorphic sarcomas. Nonetheless, this is an example that came from the retroperitoneum of an older adult. And you can see here, this aspirate smear shows a typical appearance of any high-grade sarcoma, where we will often see large tissue fragments of pleomorphic cells, as well as singly dispersed cells between the tissue fragments and in the background. And that's often where you can really appreciate the significant pleomorphism of these tumor cells. While I stated that these tumors can be associated with a longstanding fatty mass, oftentimes the precursor or associated ALT, WDLPS is not sampled on FNA, and thus this is not necessarily recognizable as a fatty tumor. Here's another image showing that significant pleomorphism. And really you can see this wide range of nuclear size where they can be upwards of 20 times larger than the 20 times size differences between the smallest and largest tumor cell nuclei. Here you can see, again, this significant striking pleomorphism. And there really isn't any distinguishing features, again, in this smear either. In some areas, you may see some entrapped vascular structures, but again, that's a very nonspecific finding and arguably can be a mimic of myxofibrosarcoma, which we will talk about later in this lecture. And in some cases, you may not get large tissue fragments. You may just see these myxoid, an extensive myxoid stroma and these pleomorphic cells strewn about in the background and singly dispersed. But that makes it easier to recognize that pleomorphism. So what would we look for if we looked for the accompanying ALT or WDLPS if it's sampled? Well, these can be quite subtle. They vary from appearing lipoma-like to showing denser tissue fragments with recognizable atypical hyperchromatic stromal cells and mixed between the fatty cells. We often describe these fat cells to have variation in adipocyte size, which I think is most appreciable in the upper right hand, but really the upper left hand shows that this can be very subtle. One thing to tell apart that helps you tell this apart from normal fat or even a lipoma is that these tissue fragments are often quite large. Well, you'll often get smaller tissue fragments dispersed when you sample subcutaneous fat or a lipoma, where the fat cells are often grouped in tumor groups less than 10 cells. So dedifferentiated liposarcoma can really show any morphology, and most are non-lipogenic. These often show a high-grade morphology, but some examples may be low-grade. And these are often nondescript, but specifically on histologic sections, it's important to remember that these can mimic other known sarcoma types, including leiomyosarcoma, malignant peripheral nerve sheath tumor, and myxofibrosarcoma. And that's just important to remember in the retroperitoneum, in that dedifferentiated liposarcoma is going to be your chief diagnosis or on top of your differential diagnosis. As I stated before, the precursor ALT or WDLPS may not be sampled, but is helpful if present. Lipoblasts are not necessary for the diagnosis of dedifferentiated liposarcoma, despite its name, and are actually typically absent in the majority of cases. However, rare cases, which we'll revisit later in this talk, may show what we call homologous dedifferentiation, in that the high-grade transformation shows differentiate towards a lipogenic phenotype, and these tumors mimic pleomorphic liposarcoma. Lastly, I'll point out that about 10% of cases will show heterologous dedifferentiation, most commonly the forms of rhabdomyoblastic or chondro-osseous differentiation, although those may not be sampled on fine needle aspiration. And I'll just point out that myogenic differentiation is associated with worse prognosis if present. So what can we use for ancillary studies for dedifferentiated liposarcoma? Well, these are characterized by chromosome 12q14 to 15 amplifications. And this is This area encodes the gene loci for MDM2 and CDK4. This corresponds with overexpression of these protein products, which we can identify by immunohistochemistry, which is positive in most cases. It's important to remember that MDM2 may be focally positive in a nonspecific pattern in other sarcomas, such as myxofibrosarcoma and malignant peripheral nerve sheath tumor. For challenging cases where the immunohistochemistry may be equivocal, or if your laboratory favors using fluorescent in situ hybridization, you can use MDM2 FISH to identify this gene amplification. Lastly, I'll point out that MDM2 gene amplification is not unique to dedifferentiated liposarcoma and ALT-WDLPS, and we can also see these in intimal sarcoma. So correlation to know that whether or not this is a sarcoma that's arising out of a large blood vessel, or correlation to ensure that you're not dealing with a bone tumor, as MDM2 amplification is a feature of part osteosarcoma and low-grade central osteosarcoma. So this is an example of a cell block of a dedifferentiated liposarcoma in which we were able to identify MDM2 overexpression by immunohistochemistry, and we did perform fluorescence in situ hybridization. And you can see here the red probe showing multiple copies in each tumor cell nuclei, which corresponds with the amplification of the gene. So moving on to pleomorphic leiomyosarcoma. This is a tumor of middle-aged to older adults and arises in the deep soft tissues of the extremities and rarely in the retroperitoneum. These tumors often arise and associated with a large vessel, such as the inferior vena cava. And as I stated before, it is the second most common pleomorphic sarcoma after dedifferentiated liposarcoma in the retroperitoneum. These tumors have a complex karyotype with no defining recurrent molecular features. And so we know that these tumors are going to be comprised of pleomorphic cells that are often singly dispersed, frequently binucleated and multinucleated. The spindle cell component of a conventional leiomyosarcoma may be present, and these will appear as densely cellular fascicular fragments. On H&E, whether or not it's a cell block or resection, these tumors have eosinophilic cytoplasm, though I'll point out that they're not as bright as pleomorphic rhabdomyosarcoma. So oftentimes the pleomorphic cells of a leiomyosarcoma will be singly dispersed, and you can see crushed areas where these tumor cells come out, but you can also see these single tumor cells, and this one is binucleated, singly dispersed apart from there. And these smears may appear hypercellular, but as you look at them, you will pick up on these pleomorphic cells. And I think we can all agree that these are fairly nonspecific appearing. So this is where ancillary studies may come in handy. Again, just to reemphasize the fact that these tumor cells on their own really don't give any hint that these come from a smooth muscle tumor. However, if you do sample a conventional component of a leiomyosarcoma, you can have this can clue you in, as leiomyosarcomas are spindle cell neoplasms conventionally, and these often show long fascicles that often intersect, and these cellular fascicles are crowded, highly cellular, with atypical nuclei that are spindled, that we all know on cytology that we have to focus up and down to appreciate the tumor cell morphology. So where does immunohistochemistry come in? Well, it's most helpful in that we can identify smooth muscle differentiation by SMA and Desmond positivity. Desmond positivity can be helpful to support your diagnosis. However, this is only positive in up to 60 to 70% of tumors. Given the Desmond positivity, you may still have to consider pleomorphic rhabdomyosarcoma, and we'll go over an example of that next. And these are negative for myogenin and MyoD1. These are also negative for MDM2 and CDK4. And one pitfall to remember is that you can see focal positivity for keratin in pleomorphic leiomyosarcomas and leiomyosarcomas in general. For tumors that arise in the abdominal cavity or in the retroperitoneum, you may also consider a gastrointestinal stromal tumor, and these are negative for KIT and DOG1. And you may also consider a malignant peripheral nerve sheath tumor given the spindle cell morphology, and these are negative for S100 and SOX10, which would also exclude melanoma. So this is just an example of a histologic section of a pleomorphic leiomyosarcoma where you can see both the conventional fascicular parts, but the pleomorphic tumor cells distributed throughout the section. And these will often show diffuse SMA and desmin positivity. Pleomorphic rhabdomyosarcoma is very, very rare. This is a tumor, one of the rare rhabdomyosarcoma subtypes that's most common in adults. These patients are typically older with a slight male predominance. These most commonly arise as deep-seated masses in the lower limbs, and these are fairly aggressive, as we noted before, where these have a metastatic rate of greater than 90%. These tumors have an aggressive presentation as a rapidly growing mass, and unfortunately, the median survival of these patients is less than 8 months from diagnosis. These pleomorphic sarcomas look fairly nondescript, which is why immunohistochemistry can be quite helpful. We'll see, as expected, large pleomorphic nuclei. Specific to pleomorphic rhabdomyosarcoma, these tumors may show more specifically polygonal or epithelioid morphology, some with abundant cytoplasm. These tumors have characteristic abundant, brightly eosinophilic cytoplasm, but that of course would not be appreciated on conventional FNA smears, whether or not you stain yours with Papa-Nicolau stain or with Romanowski stain. I guess some practices use H&E stains, however, that's not the case at our institution. We'll see frequent binucleation and multinucleation in tumor cells, similarly to pleomorphic leiomyosarcoma. Some examples may show rhabdoid forms with a very epithelioid appearing cell with a prominent cytoplasm that almost protrudes and has an eccentrically placed round nuclei. Because pleomorphic rhabdomyosarcoma is so aggressive, you will often see necrosis and frequent mitotic figures in your aspirate smears. So here's one example of a pleomorphic rhabdomyosarcoma where you can really appreciate the pleomorphism on this alcohol-fixed smear. Here you can see there's often an abundant necrotic background, which can make it difficult to pick out the tumor cells. What I highlighted here is this tumor cell that looks somewhat rhabdoid and that has this eccentrically placed nuclei and protruding cytoplasm. And so looking for those cells may be helpful and clue you in to include myogenic and skeletal muscle markers in your immunohistochemical panel. Here again, you can see where the tumor cells are intact with this abundant necrotic background, and then you can see more epithelioid forms on occasion, but again, these pleomorphic nuclei really are nondescript in the grand scheme of things in your differential diagnosis. On H&E, these are often brightly eosinophilic, much more so than pleomorphic leiomyosarcomas. And what do we use for immunohistochemistry? Well, these will show strong desmin staining, and it'll be the strongest desmin staining amongst all myogenic type tumors. These will also show multifocal staining for myogenin and MyoD1. And again, these are skeletal muscle specific markers that are required to support rhabdomyoblastic differentiation. And that's important because of the pitfalls that these tumors may show SMA and keratin positivity. And so in a lot of examples, these cases may be difficult to tell apart from a pleomorphic leiomyosarcoma. These are negative for MDM2 and CDK4 should dedifferentiated liposarcoma be in your differential diagnosis. And here you can see again on histologic section, this brightly eosinophilic cytoplasm with highly pleomorphic nuclei, and in some cases the pleomorphic or the eosinophilic cytoplasm may impart a rhabdoid appearance. This shows brightly, very strong desmin staining and scattered nuclear myogenin staining, and this would be diagnostic of pleomorphic rhabdomyosarcoma. So what about extraskeletal osteosarcoma? These are very rare, but will enter your differential diagnosis in many cases. These arise in adults, middle-aged to elderly, in contrast to conventional osteosarcoma of the bones, and these also show a slight male predominance. These typically arise in the proximal extremities, and most are deep-seated. 10% of cases are reported reported to have a prior history of trauma or radiation. And these tumors, similarly to pleomorphic rhabdomyosarcoma and pleomorphic leiomyosarcoma, have a complex karyotype with no specific recurrent molecular features. So how do we define osteosarcoma? Well, the definition is based on histologic grounds, and this is defined by the presence of neoplastic osteoid that are produced by malignant pleomorphic cells, thus recapitulating osteoblasts. However, visualization of osteomatrix can be extremely challenging on cytology. Matrix production can be hard to tell apart from myxoid material. Osteoblastic morphology, if present, can be helpful, particularly for osteoblastic type osteosarcoma. And the presence of osteoclast-like giant cells may be present, but of course are not non-specific. As you can see, osteoclast-like giant cells in many soft tissue sarcomas, as well as several types of undifferentiated carcinomas. So here's a low power view of an extraskeletal osteosarcoma that we saw at our institution. And you can see that this is showing large fragments of pleomorphic cells, which again appear relatively indistinct. We can see the singly dispersed pleomorphic cells in the background. And again, one helpful clue that at least makes you think about, could this be an osteosarcoma, is the presence of this osteoclast-like giant cell. And so when I see that, of course, as I mentioned a moment ago, we would think about carcinoma, but perhaps in an older adult, you may think about an extraskeletal osteosarcoma. So we'll look for osteoid. In this smear, this only confirms that this is a malignant neoplasm. As you can see that there's mitotic activity. This is highly cellular with significant pleomorphism in the tumor cells. And we are seeing more of the osteoclast-like giant cells. As we look further, there perhaps may be a hint that there's extracellular matrix in this tumor fragment. And so this pale, or not pale, but brightly eosinophilic extracellular wiry material is osteoid. However, looking at this, say this came from a salivary gland, you may consider that this looks like the extracellular fibrillary matrix that you might expect in a pleomorphic adenoma. So this osteoid material can be very nondescript appearing. Nonetheless, if you look carefully and you see some material that is suggestive of it, you should think about osteosarcoma. Here is another example of how subtle this osteoid material can be. Because the tumor cells make this, the appearance of osteoid can often be very lace-like in that it interdigitates between the tumor cells, where we know in histologic section that you would see these tumor cells embedded and surrounded by this delicate malignant osteoid. And so again, this very kind of dense, brightly eosinophilic material that's lacy between the malignant cells is a clue to at least think about osteoid material. In some cases, the osteoid may be somewhat harder or more mineralized, and that may also be apparent in some of the tissue sections if you have a thin enough section or a thin enough area on your smear to appreciate that. And so this material here, I think, is much more suggestive of osteoid, given that it had a refractile quality under the microscope. So what do we use to identify osteoblastic differentiation? Well, SATB2 immunohistochemistry, as mentioned before. And this is a very sensitive and specific marker for osteoblastic differentiation. However, it's important to remember a few caveats. One is that SATB2 positivity is not specific for determining malignant versus benign tumors. It just confirms osteoblastic differentiation. SATB2 is also a marker of colorectal differentiation, so that's important to keep in mind if you're considering a poorly differentiated colorectal adenocarcinoma, which may make mucinous material. And focal SATB2 can also be seen in other pleomorphic sarcomas, so it's important to look at the pattern of staining as well as if there's convincing osteoid in your sections and in your smears. Some notorious pitfalls to keep in mind is that extraskeletal osteosarcomas can show positivity for SMA, desmin, EMA, and keratin. And so when you see osteoblastic or chondro-osseous and osseous differentiation, you also have to think about the possibility of heterologous differentiation in other malignancies. So we mentioned earlier that this can be a feature of dedifferentiated liposarcoma. So you may consider adding MDM2 and CDK4 to your immuno panel. You could also think about excluding malignant peripheral nerve sheath tumor with S100, SOX10, and the histone marker for the lysine 27 trimethylation mark. And lastly, you could also think about carcinosarcoma as a clinical correlation if you happen to have an older adult patient that is female, to consider whether or not there was a past history or current history of a uterine mass. And using a keratin marker, and if relevant, a Paxate marker, if there is a Mullerian carcinomatous component represented, can exclude this possibility. So just showing this was actually a miraculous cell block that we got, where we got a nice big section from that case, and that confirms this kind of lace-like osteoid that's interdigitating between these pleomorphic cells, confirming the diagnosis of osteosarcoma. But we also did ASCP 2 immunohistochemistry to confirm osteoblastic differentiation. So moving on to myxofibrosarcoma. This is the most common sarcoma in elderly adults, as mentioned earlier. These most frequently arise in the limbs and subcutaneous locations, and greater than 70% are subcutaneous. These are very rare in deep-seated sites, particularly in the retroperitoneum and in the abdominal cavity. These tumors are very infiltrative and recurrences are frequent. And specific to your resection specimens, grade is prognostic, and this is based on cellularity. So this is not a feature that we can readily identify in many cases in cytologic material. And myxofibrosarcoma has no specific immunophenotype and has a complex genetic profile. So this is the first of 3 of the sarcomas in our differential diagnosis, in which the morphologic features are required for specific morphologic features are required for diagnosis, but it may not be possible on FNA material. So what are the diagnostic features if present? Well, curvilinear vessels and a variable amount of myxoid matrix. Of course, in higher grade tumors where there's increased cellularity, the myxoid matrix may be obscured and the curvilinear vessels may not be readily visible. So these will show pleomorphic spindle or epithelioid cells. And it's important to remember that these may be indistinguishable from other pleomorphic sarcomas, but because they lack a specific immunophenotype, they're essentially indistinguishable from pleomorphic liposarcoma and unclassified pleomorphic sarcoma if your other markers are negative. The atypia may be very mild in low-grade tumors. And you may also see unusual features such as prominent epithelioid morphology, particularly in high-grade examples of myxofibrosarcoma. One pitfall is that you may see pseudolipoblasts, which are tumor cells that have vacuolated cytoplasm secondary to the abundant myxoid matrix of many of these tumors. And this may be a pitfall for true lipoblast, as you might have to consider pleomorphic liposarcoma in your differential diagnosis. And of course, with higher grade tumors, we'll see increased cellularity as well as atypia and necrosis. So this is a low power view of a typical smear of a myxofibrosarcoma, showing the large tissue fragments with abundant myxoid stroma and curvilinear arcuate thin-walled vessels. These vessels often have tumor cells that coalesce around them and often appear to spill off of them in your myxoid tissue fragments. And you may, with the higher grades and increased cellularity, you'll see the pleomorphic cells strewn in the background. But really looking at these tissue fragments and appreciating the myxoid stroma and the curvilinear vessels is very helpful. Here, just to highlight this curvilinear vessels and the myxoid stroma that is embedded around it. And again, you can see these tumor cells seem to spill off and coalesce around these vessels. On a Papanicolaou alcohol fixed stain, you can also appreciate this. And this is one where the pleomorphism may not be as striking, but the curvilinear vessels are a helpful feature. And in some examples, the vessels may not even be sampled, and that can be quite challenging, as you'll get abundant myxoid stroma and pleomorphic tumor cells, and this would be very hard to tell apart from dedifferentiated liposarcoma, as well as the other entities that we'll discuss in a moment. Some examples, as I mentioned before, may show more epithelioid morphology, and looking at this is relatively indistinct as well. However, in this epithelioid example, in another area, we found a curvilinear vessel, which favored the diagnosis of myxofibrosarcoma. And here's another example here where you can see this really striking pleomorphism. But again, for the most part, there are large tissue fragments and cellular cohesion, as well as the pleomorphism that helps you at least recognize this as a sarcoma. Here, I just wanted to highlight a pseudolipoblaст, which is a tumor cell with somewhat vacuolated cytoplasm here. These are just histologic sections showing low-grade tumors and where you can see the increase in cellularity to the right to a more high-grade tumor where the curvilinear vessels are sometimes shown in the less cellular areas, but there's increased cellularity throughout. So the FNA diagnoses are often descriptive for these, and we'll go over why as we discuss pleomorphic liposarcoma and unclassified pleomorphic sarcoma. We often, what I often diagnose these as is high-grade pleomorphic and myxoid sarcoma, favor myxofibrosarcoma, if I see myxoid stroma and curvilinear vessels, and I don't see any lipoblast. Curvilinear vessels and myxoid stroma are the most reproducible features of myxofibrosarcoma. However, not all cases will show these features, and sometimes will warrant a descriptive diagnosis where we can't even favor myxofibrosarcoma. But these features may also be seen in pleomorphic liposarcoma. And so, as we'll discuss, the absence of lipoblast will favor myxofibrosarcoma. However, we are always subjected to sampling errors on FNA, and so we may not see any of these definitive features on your aspirate smears. However, curvilinear vessels and myxoid stroma should not be present in most examples of unclassified pleomorphic sarcoma. So, pleomorphic liposarcoma. This is the least common liposarcoma subtype, comprising 5% of all liposarcomas, and overall very rare across all sarcoma types. These are tumors of older adults, typically after the 7th decade, and most examples arise in the extremities, in which these are more common in deep-seated sites compared to subcutaneous sites. So this is in contrast to myxofibrosarcoma, which is more common in the subcutis. These tumors show aggressive behavior with up to 50% rates of recurrence and metastasis. And similarly to myxofibrosarcoma, there's no specific immunophenotype or molecular features. So these tumors will typically show large cellular fragments with often an admixed fatty component. And that is a feature that will help identify pleomorphic liposarcoma in this differential diagnosis, with the caveat that you would still have to exclude dedifferentiated liposarcoma. These are comprised of pleomorphic and spindle tumor cells, which are highly atypical and often indistinct appearing. And the nuclei can be extremely large. And I point this out in that pleomorphic liposarcoma is notorious for having some of the largest tumor cell nuclei across all sarcoma types. And this can be quite a fun feature to see. Mitotic figures and necrosis are very common in most examples. And as I pointed out before, the features of myxoid stroma and curvilinear vessels may be present. And so really the only difference between these and myxofibrosarcoma are the presence of lipoblasts. And in fact, lipoblasts are actually the sole diagnostic criterion for pleomorphic liposarcoma. These lipoblasts are often large and atypical. They may only be focally present, so that can be quite frustrating, particularly when we are dealing with FNAs given the sampling errors. And they may be absent entirely altogether, which is why some examples may only have a descriptive FNA diagnosis. So this is a typical example of a pleomorphic liposarcoma. You'll often get these very large tissue fragments in which you can see from the get-go that there's a lot of fatty cells admixed in this tissue fragment. And as we look more carefully, a lot of these fat cells have multiple vacuoles, which is one of the features of pleomorphic or one of the features of actual lipoblasts. As we see other tissue fragments, again, a very cellular smear comprised of numerous tumor cells, numerous pleomorphic tumor cells, but you can see that there's a lot of lipoblasts in here, and these lipoblasts are even more recognizable in that they have optically clear vacuoles that indent and scallop a hyperchromatic nucleus, and we can see that here and in this example here with the multiple vacuoles creating these kind of indentations in that lipoblaст nuclei. And so I really want to just emphasize that these lipoblasts should be looked at with scrutiny, so that you don't mistake pseudolipoblasts or histiocytes or just fat cells for lipoblasts. And so you can see here the on histologic section in this example, again, a hyperchromatic nucleus, often having very vesicular and hyperchromatic chromatin. And this, again, this nucleus has to be scalloped and indented by multiple vacuoles. And so when you're lucky, you'll see a lot of tissue fragments that have these lipoblasts embedded within the pleomorphic tumor cells. And on histologic section, you can see here that these lipoblasts are scattered throughout the section. And in this case, after you exclude dedifferentiated liposarcoma with homologous differentiation, you can make the diagnosis of pleomorphic liposarcoma on this section alone. Now, some examples, the lipoblasts may be extremely focal, as mentioned before. And so this is an example of a pleomorphic liposarcoma in which the liposarcoma are very scarce. And looking at a smear like this, it's fairly nondescript. And so this is one where you will have to think about both myxofibrosarcoma and pleomorphic liposarcoma. And say on histologic section, if you don't have myxoid stroma with curvilinear vessels, or lipoblast, this would be diagnostic of unclassified pleomorphic sarcoma. And so this pleomorphic liposarcoma really had very scarce lipoblasts as we look throughout the smear slide. But on the histologic section, these lipoblasts were only very rarely scattered throughout the tumor. So this is an example in which a lipoblasts being very focal make the diagnosis of pleomorphic liposarcoma very challenging, both on FNA and on surgical resection. So if I have not emphasized strongly enough, lipoblasts are the sole diagnostic criterion and may not be sampled. And so if these lipoblasts are absent, your FNA diagnosis should be descriptive and give a differential diagnosis, where we have to state that you can't exclude myxofibrosarcoma and unclassified pleomorphic sarcoma from pleomorphic liposarcoma. While it is important to remember that pleomorphic liposarcoma is much rarer compared to those other two tumor types, but again, that will not really help us with our FNA diagnosis. But in the retroperitoneum, if you saw any smear that resembled pleomorphic liposarcoma, you'd have to consider dedifferentiated liposarcoma, as that's the most likely diagnosis. And I would encourage MDM2 testing for any tumor that has lipoblasts and pleomorphism in the retroperitoneum. Because this is an example of dedifferentiated liposarcoma with homologous dedifferentiation. And so you can see here in this tissue fragment that this is not that different from the pleomorphic liposarcoma examples that I showed, with these pleomorphic cells intertwined and enmeshed with these pleomorphic lipoblasts. On histologic section, this looks really no different from the pleomorphic liposarcoma examples that I showed earlier. However, this showed diffuse MDM2 staining, and this was diagnostic of dedifferentiated liposarcoma. So again, in the retroperitoneum, seeing a smear pattern that would normally make you think about pleomorphic liposarcoma, you have to exclude dedifferentiated liposarcoma. If MDM2 is negative, then you would have to consider a metastasis. So lastly, we'll talk about undifferentiated pleomorphic sarcoma. This is formerly known as malignant fibrous histiocytoma. In the last two World Health Organization classification schemes for soft tissue and bone tumors, this MFH terminology has been basically abandoned. And so these, and we've learned over the years that most cases of malignant fibrous histiocytoma ended up being able to have more specific diagnoses with careful histologic examination and application of ancillary studies that came to light long after the original diagnoses of MFH years and years ago. So undifferentiated pleomorphic sarcoma is really a diagnosis of exclusion, and this is defined as having no identifiable line of differentiation. These are overall rare. These arise in the limbs more frequently than the trunk, and those two sites are more common than the retroperitoneum. And most of these are deep-seated in somatic soft tissue sites. And similarly to myxofibrosarcoma and pleomorphic liposarcoma, these have no specific immunophenotype and have a complex karyotype. So not surprisingly, these will show very similar features to all other pleomorphic sarcomas in our differential diagnosis. Highly cellular smears with large cellular groups in single cells, pleomorphic and anaplastic cells with multinucleated giant tumor cells frequent. Oftentimes seeing numerous mitoses, including atypical forms and necrosis. So this is an example of an unclassified pleomorphic sarcoma that was confirmed on resection. Of course, at the time of diagnosis, we did exclude dedifferentiated liposarcoma, pleomorphic rhabdomyosarcoma, pleomorphic leiomyosarcoma, and we didn't see any features of osteoid and didn't test for SATB2 in this example. But you can see here a fairly nondescript appearance where this would be really hard to tell apart from any other tumor that we've discussed earlier. Here again, large tissue fragment with numerous pleomorphic tumor cells and really no specific features. And you can look at a smear and see that there's no myxoid or no curvilinear vessels that would be indicative of myxofibrosarcoma and no lipoblasts. But of course, we know that a smear like this could be an example of either myxofibrosarcoma or pleomorphic liposarcoma, in which those specific features were not sampled. And here again, you can really see the pleomorphic cells strewn about, and this is not dissimilar from the earlier examples of pleomorphic leiomyosarcoma that I showed. And just really wanted to emphasize how large these tumor cells can get. Again, one's tumor cell here, and then a significantly larger one there. On histologic sections, these look fairly nondescript, and after a descriptive FNA diagnosis with a differential diagnosis, these tumors get extensively sampled by histology and confirm that there's no other features that would be diagnostic of either myxofibrosarcoma or pleomorphic liposarcoma, and you've excluded all other sarcomas with your ancillary studies, then you can arrive at a definitive diagnosis of unclassified pleomorphic sarcoma. And this is one example in which there are abundant inflammatory cells, and this in the past was called inflammatory malignant fibrous histiocytoma, but we know that this is a very nondescript variant of unclassified pleomorphic sarcoma. So as I said before, this is a diagnosis of exclusion. So we need to exclude all other sarcoma types as well as carcinoma, melanoma, and lymphoma. And so the immunohistochemical studies that I recommend, we've all discussed throughout this talk, including MDM2, CDK4, starting off with the Desmond and SMA to address your myogenic tumors, keratin S100 and LCA. Most FNA diagnoses will end up being descriptive unless there is a prior diagnosis and you're dealing with a recurrence. And again, the key histologic features of myxofibrosarcoma and pleomorphic liposarcoma may be focal or not sampled, which is why we stick with the descriptive FNA diagnosis. So this is just a table summarizing the salient features that we've talked about in this differential diagnosis with the helpful clinical features, which include dedifferentiated liposarcoma being the most common in the retroperitoneum, myxofibrosarcoma being the most common sarcoma in the elderly and typically in superficial sites in the limbs, and pleomorphic leiomyosarcoma sometimes being associated with a large vessel. The helpful cytomorphologic features that we've discussed include whether or not ALT, WDLPS may be sampled in a dedifferentiated liposarcoma. Of course, we've really emphasize the myxoid stroma and curvilinear vessels of myxofibrosarcoma and the requirement of lipoblast for the diagnosis of pleomorphic liposarcoma, and the subtle features of osteoid for extraskeletal osteomyosarcoma. If we see a conventional fascicular component, that might favor a pleomorphic leiomyosarcoma, and large epithelioid or rhabdoid cells would favor a pleomorphic rhabdomyosarcoma. And these are the immunostains that we've discussed before that are helpful in many clinical contexts to exclude. So in summary, be aware of the typical clinical features and relative frequencies of these sarcoma types in your differential diagnosis. ancillary testing really has a useful role. And if triaging for cell block material is possible, I really encourage it because it can be helpful for stratifying these tumors, being that dedifferentiated liposarcoma has the lowest metastatic risk, and pleomorphic leiomyosarcoma and pleomorphic rhabdomyosarcoma have the highest rates of metastasis. Of course, excluding these mimics, carcinoma, melanoma, and lymphoma. It's important to remember that dedifferentiated liposarcoma will show a broad morphologic range, including cases that perfectly mimic pleomorphic liposarcoma and myxofibrosarcoma. And as we've really discussed thoroughly, the many overlapping features between myxofibrosarcoma, pleomorphic liposarcoma, and unclassified pleomorphic sarcoma make it very hard to make definitive diagnoses on FNA material, being that none of these have distinct immunochemical or molecular features, and thus a descriptive diagnosis in the absence of specific features is typically the default. And when you do get these on surgical resection, sample thoroughly so you can make a definitive diagnosis. And with that, I'll conclude and I'll be happy to take any questions. Thank you.
Thank you. Thank you so much, Vicky Jo and Leslie, for that presentation. We do have one question that I saw, which is from Alex and Remy, who is at KCMC Hospital in Moshi, Tanzania. He asked, Vicky Jo, do you always do rapid on-site evaluation for smear sample adequacy, Rose preparation? Is that standard of care where you work?
So, I'm always hesitant to say standard of care when it comes to FNA practice, because a lot of the things that affect our practices relate to whether or not you do them by palpation or if you do them in concert with your radiologist. And, we're all kind of subjected to a lot of pressures. But at our institution, we do rapid on-site evaluation for for most fine needle aspirations of soft tissue tumors. And that's in part because we have the luxury of having a large sarcoma practice at our institution. It's a large referral center. And so we are accustomed, after having many cases in which the clinicians were frustrated with us for not being able to have a definitive diagnosis when they wanted, they've been incentivized to call cytopathologists for the on-site rapid evaluation. And so we do that. We have definitely hammered into our trainees that we should always triage for fine needle, for cell block material if we can, and particularly if the fellow is doing the FNA with the patient by palpation in our clinic. And so we really encourage it if possible, but also recognizing that this isn't always a possibility due to staffing or just local practices of your fellow clinicians. But if possible, I would really encourage it.
Thanks.
But I would hate to say something's the standard of care because I know we're all, have different practice settings.
Yeah, thanks so much. And that question comes from Alex, who is in Moshi, but in Dar es Salaam, not too far away. Diana Ng has worked very closely with Estella and Marie Claire, who's now back in Rwanda, to train people to do Rose. So they are trying to bring Rose online in Tanzania in a big way for many reasons, especially around breast. So that was the basis primarily of his question. If there are any other questions, please feel free to put them in the chat box. We have probably time for one or two more questions. If you have questions that you would rather not ask now, you can email me those and we will make sure that you get them answered. Leslie, did you have any questions for Vicky Jo after seeing the presentation as an expert?
Yes, thank you. Thank you so much, Dr. Jo, for that wonderful presentation. So I just wanted to confirm then you're not, in your group, you're not moving to core biopsy of soft tissue lesions, is that correct? At our institution.
And Leslie is familiar with our institution, as she also came from here. So we have a very strong leadership in bone and soft tissue pathology in our division. And so Chris Fletcher and Jason Hornick, particularly Chris Fletcher, has been part of the generation in which they really discouraged core needle biopsies of soft tissue tumors. That was when there were less very specific ancillary studies that were diagnostic. What we found is that we've gotten a lot of highly sensitive and specific diagnostic markers that are available now, is that they've softened their stance on it. so, as an institution, we see more and more core needle biopsy done by our interventional radiologist. But we are not an FNA practice that does our own core needle biopsies. I know particularly the Karolinska Institute in Sweden is notorious for having their cytopathologists do both the core needle biopsy and the FNA, but we do not perform them ourselves. When they're done by interventional radiologists, we have actually really been successful in campaigning them to do both in a rapid on-site evaluation to make sure that they're getting good material. And this is helpful because a lot of sarcomas can be highly necrotic. And so we'll actually do a rose, and then once we've confirmed that there's good cytologic material and we do still triage for cell block, they'll actually do a core needle biopsy for us then and there. So I think a lot of the culture has shifted against the anti-core needle biopsy stance that many of us kind of learned when we were young.
Yeah,
Great.
thank you for that. And if I could just squeeze in just one more question. I just wanted to ask, what is the practice of the care of patients, particularly with neoadjuvant treatment? So the other thing that I've been exposed to here in this institution is that actually a fair number of patients will undergo neoadjuvant treatment. So then that puts more pressure, right, on how do you classify these entities on these small samples? So I wanted to hear your perspective if you've seen any shift in your practice.
So I think we probably see similar practices at our institution, since you're also at a large academic institution where a lot of patients will get neoadjuvant chemo and or radiation prior to resection. And so, we all have struggled with post radiation, in particular radiation, samples of soft tissue tumors in which a lot of the pleomorphism can be exaggerated, and a lot of the normal histologic features can be distorted or just absent. And so that's particularly the case for myxofibrosarcoma, pleomorphic liposarcoma, and unclassified pleomorphic sarcoma, where you may not even be able to get a definitive diagnosis on resection. However, because as I showed in that table on my, I think, second or third slide, those kind of cluster together with their metastatic risks. And it's actually okay to have a descriptive diagnosis with where you've kind of left those three possibilities and have excluded dedifferentiated liposarcoma, which has a much lower risk, and then there are myogenic sarcomas, leiomyosarcoma and rhabdomyosarcoma, which have a much higher risk. And so with relation to that, if you're able to exclude the two ends of the spectrum, it's actually not going to really create a negative impact if you end up not being able to diagnose a patient definitively when you're left with those three diagnostic possibilities in the end. So that may be somewhat unsatisfying to us because we definitely like to have our definitive diagnoses, but it doesn't have a negative impact on patient care in that they'll all get appropriately treated, even if we don't have a final answer in the end. But with pleomorphic rhabdomyosarcoma and leiomyosarcoma, they sometimes are more aggressive with their treatments because of, they're more aggressive tumors. And so in that case, I do like to try to, exclude those when I can. And so I hope that addressed your question.
No, that's perfect. Thank you. I just wanted to sort of illustrate. I mean, there is the acknowledgement, as you obviously pointed out, that practice patterns vary. Regional practice patterns are going to vary tremendously, but there are these big trends now that I think will undoubtedly impact like a ripple effect across the spectrum. And so it's just good for everybody to sort of be aware of what's coming.